Hello and welcome to the PCR webinar. We are excited to broadcast the first PCR webinar in association with India Valves. I have three handsome and very famous men with me who are going to talk about TAVI, both in Europe and, of course, in India too. And hopefully, it will be an educational exchange, which we hope to continue for a long time. I will pass over to my co-chair, Bernard Prendergast, who needs no introduction.
So thank you very much, Gopi, and good evening to everyone in India, and good afternoon from here in England, UK. It's a huge pleasure to be with you and a great cause for celebration to mark the inaugural webinar linking the PCR organisation with India Valves. So the links between India and Europe and England are long-standing in history, and in terms of interventional cardiology, we've been linked for many years, firstly through educational links with numerous fellows who spent their time in Europe learning their craft in interventional cardiology, and also in educational terms, linking PCR with key individuals in India, notably Ashok Seth, a senior cardiologist in Delhi, who has been a long-standing friend of PCR and has helped to cement our friendship and collaboration. But we should always remember that even the best friendships can be tested from time to time. And we speak this webinar at a time when India are playing England, and we are competing with the match as we speak. And for those who are unable to watch, I can let you know that India were 358 all out earlier on this afternoon, and England are batting very well at 80 without loss of wicket after only 14 overs. So the times are looking challenging for India. And we also want to be sure that we have no repetition of any tension or argument. If we could move to the next slide, please. We want to avoid any confrontation in this seminar, in this webinar particularly. Now, just like cricket, structural heart intervention is expanding very rapidly worldwide. And PCR is very proud to host a network, a global international collection of courses that are now distributed across the 5 continents and led by Didier Cheche, who is our international coordinator for valve courses. In South Africa, in Latin America, in Asia, in China, Japan, we have been working on these collaborations for many years. Next slide, please, advance. And we are very proud to bring our collaboration together with colleagues in India through this webinar and ongoing collaborations. The root of the collaboration, however, comes from London. The first valve course within the PCR family was London Valves, that was established 15 years ago in 2010, when TAVI was in its infancy and just establishing its foothold in Europe and in the UK. And in a very modest meeting of only 800 participants over 2 days, we were able to focus on transcatheter aortic valve implantation for the first time, and in particular the synergy with imaging, which remains very important to the present day. Over the years, the course has grown to encompass the mitral and tricuspid valves as well, so much so that in 2024, we had over 4,000 people congregated in London, including many representatives from India who brought their clinical experience and their cases for educational benefit of the entire community. And the keynotes of the London valve recipe are summarized here. And you can see that we now have a focus on 3 valves. And importantly, in 2025, for the first time, we will be extending beyond the valves to also encompass non-valvular structural interventions, particular paravalvular leak closure, left atrial appendage closure, and other aspects of structural intervention. And during this course, we'll be celebrating and marking our 16th year, and you can see that the dates are summarized for you here, and we hope that as many as possible of the Indian community will join us for this global collaboration. So the objectives of our webinar today are summarized on this slide. Our focus will be on the aortic valve, and we will be attempting to run through the basics of the procedure, the fundamental steps, and focusing on detail on some of the important educational messages. And to do so, we will be joined by a fantastic collaborative team. You know these individuals extremely well. Gopi has been instrumental in developing the collaboration and organizing the platform. Sengo is very well known to you and undertook his fellowship at Massy in France many years ago and is a long-standing friend of PCR. And Didier Cheche is well known to the entire community for his interventional skills and his leadership now of the International PCR Valve Network. So Didier, there has been a huge growth in activity of structural valve intervention across the world. Give us an overview of what you see as the latest trends and developments.
Thank you very much, Bernard. So indeed, it's quite interesting to see the adoption of TAVI that we have witnessed during the last decade. It has been a tremendous increase in the number of procedures, and I'd like to say that overall the architecture, the compositions of the contemporary heart team has a little bit changed. We still have these the interventional cardiologist, the imaging physician, the cardiac surgeon, the geriatrician, the anesthesiologist. But we could also integrate as well the heart failure specialist because apart on top of TAVI, we have developed a quite huge program worldwide tackling structural heart disease in general, as you have mentioned. And London Valve is the key example of the type of meeting that we need just to address, to better learn how to treat these patients. As a consequence of the expansion of the indication for TAVI, from the inoperable to the high risk and then the intermediate and then low risk patients, there is a kind of paradigm shift into the indications. And now it's quite regular in Europe, in the Western countries, and even worldwide to consider a patient as a TAVI candidate first. Unless the patient is extremely young, as a TAVI candidate first, and then if the anatomy is not suitable, to go for a surgical aortic valve replacement. So that could be a shift in the time of decision making for our patients. TAVI first, and then if the patient isn't suitable anatomically wise, we consider surgery. And what we have seen on a local basis here in Toulouse, but it's the same trend, at least in the Western countries. For 10 years now in a row, we have seen an increase in the number of procedures the number of patients that we have to treat. So we had to be quite creative. We had to be very efficient and to optimize the overall TAVI pathway of our patient. To make sure that we could absorb the overload of patients and being able to treat them in a very safe way, and anticipating and promoting an early discharge for these patients to be able to treat more patients. So we had to adapt our techniques, our overall pathway, the overall pathway of the patients, even simplify the procedures. And I'm glad that we will be able during this webinar to compare the practice from Europe to India, but definitely trying to be more efficient has led to the ability to treat more patients in a safe way and to early discharge these patients. And that is something that is quite important, because there is that debate about the at least in Europe, the possibility to treat the patients at centers without on-site surgery, even at low volume centers. And coming from the US data, what we saw, and it's very interesting, the kind of relationship that we can see between the volume, the experience of the centers and the operators, and the mortality. And it's really striking to or reassuring to see that the greater is your number of procedures, the greater is your experience, and the better you're going to be at treating your patients with lower mortality and a reduction in the likelihood of any complications leading to mortality of your patients. So this is really a call for keeping, at least in Europe and Western countries, keeping the procedures at high volume centers with a minimal number of procedures. And here the cutoff of 50 cases per center, or 20 to 30 cases per operator, seems to be the sweet spot to guarantee the safety and the decrease in mortality for our patients. Still coming from the US database, if you move from the right part of the slide with these elderly patients above 80, for whom TAVI is the clear indications for symptomatic AS, and you shift towards the left part of the slide, you can see that it's really surprising in the US to see that when the patients are below 65 years old, more than 50% of the population undergoes a transcatheter aortic valve implantation. It may mean that they have more comorbidities, but still they are super young patients, and they were offered TAVI. So is it the trend that we're going to see in the other countries? That is open for discussion, but it's already something that we are seeing and we have to reflect on. I think when we attend all the meetings and you're seeing the map of the PCR valve courses, and we are really happy to collaborate with India. Definitely in all the discussions around the type of procedure based on the age of the patient, we integrate the life expectancy of the patient. It's going to vary from one part of the globe to the other one, but if from this large surgical database, you can see that if we take a 70 years old patient, low risk patient, the average life expectancy, residual life expectancy is 12 to 13 years in Western countries. And so this has to be put into the equation. And it's more and more the case when we discuss about the best strategy for our patients. And we know at the same time that the sequence that we're going to adopt for a patient is going to have an impact on our ability to do a second procedure, whether it be a TAV in TAV, TAVI in TAVI, redo TAVI, or an explant, or anything else. If we focus on the surgical extraction, surgical explant of our TAVI platforms, it's really a challenge. It seems to be a challenge for the surgeons with a high mortality. We have to put this into perspective with the fact that these were whole cohorts of early cohort of patients, inoperable patients. So this might explain part of the mortality, but still a high degree of aortic root replacement and a high likelihood of complications, including mortality for these patients. So explanting a TAVI device is not a benign procedure, so it has to be integrated, and it is integrated into the equation when we come to discuss about the appropriate sequence for a patient, particularly when it comes to a younger patient, 65 years old and below, as it is already the case in the US. So I'm going to stop there, and this was a kind of overview. Greater number of patients treated, shorter hospital stay, decrease in the profile of the patient, and we are more and more integrating the sequence for a given patient, keeping in mind that there may be challenges, whether it be for redo TAVI or a explant. So thank you, Gopi and Bernard.
So
That's fantastic.
Thanks so much, Didier. That's excellent. So how do you reflect on that, Gopi and Sengo, when you see the international trends? What do you make of that as clinicians in India, and how does it reflect the picture that you see in your own practice?
It's fantastic to see the trend that you have shown, Didier, a steep increase in the numbers and a quick move towards younger patients, reflecting on Indian practice, which I'm sure my colleague Sengotibil is going to show in detail, we are heading that way in India. But based on where we are heading, at least internationally, do you think, Didier, that we are not too far from making TAVA as first line treatment beyond an set age, wherever we're going to put a bioprosthetic valve? Do you think we're heading towards a bioprosthetic valve patient is equally good for a TAVA?
So that's a key question, Gopi, and I do believe that we are going to learn more and more about the true durability of the TAVI platforms that we are using. We have had in the past very reassuring data, for instance, coming from the Notion 10 years data of this first of its kind randomized trial of low-risk patients, and we could see that the durability of the TAVI platform, it was a self-expanding one, matched the durability of the surgical valve. So there is also a trend towards putting surgical bioprosthesis in younger patients. So I do believe that if a patient is indicated for a surgery with bioprosthesis, discussing TAVI may be a good option. All the key is understanding first the durability of the TAVI platform, and second, how difficult it's going to be to do a second procedure, whether it be an explant or a redo TAVI. So are we going too far? I think your point is very well taken and very very important. We need to move very gently and into that direction and learn with the cases that we are doing. And we have already identified patients who are not good candidate for a TAVI, even though they are young, yes, 65, 70. Sometimes we say, okay, surgery is better, particularly for bicuspid, extremely complex ones, for instance.
Thank you, Didier.
Thanks, Didier. Sengo, over to you.
No, actually, in with the discussion, what Didier was pointing out about the life expectancy, our average life expectancy in India is 67 years. And this, when we look at this, then the average number of procedures they will look at it is most of them will have just one procedure in the natural history, or sometimes maximum two. So that actually makes a difference in taking those guidelines to India. And even the etiology of aortic stenosis, the population is so huge, and we have quite a number of rheumatic aortic stenosis also. And how far can we apply these techniques to rheumatic aortic stenosis is a real challenge because of the lack of calcification. Though we are able to open up this to some of the patients who are not able to take the surgery. So these are all a little different from what you see in the West. But learning from the West, we have really improved, taken the best practices, and in fact, the TAVI practices are getting better over the years in India now.
Another interesting question to reflect upon has been the wider attitude. So, of course, we are all converts to transcatheter technology amongst this faculty, and I'm sure many of our audience as well. But what's been the reaction of the surgical community in India? I think that would be, we've had our own sort of battles and our own debates and discussions in Europe and again in the US. How is this going down at a wider scale with surgical and general cardiological colleagues? Gopi.
Certainly, from an Indian perspective, the battles continue, and as cardiologists try and adopt these treatments very cautiously, of course, I think the heart team involvement would be better off truly in spirit rather than in words. So that is growing now. There is an increasing acceptance by the surgical community for TAVI. There are more surgeons now who are very keen to learn endovascular procedures because this has not been part of their training programs, and they have largely been open heart surgeons. Now, surgeons have an increasing appetite in India to learn these endovascular techniques, and the national body, IACTS, which is the national body for cardiothoracic surgeons, have also adopted these training programs to also train the surgeons so that they are an integral part of the heart team. Of course, the heart team will continue, but coming back to your question, I think the surgical community are certainly embracing. They accept that the science is there, the evidence is there, but now their involvement is slowly picking up, and I'm sure it'll get to the Western pickup rates very soon.
And Sengo, what about the most important people of all, the patients? Is there a big enthusiasm amongst patients for transcatheter technologies?
What we have seen is this is really a big thing what we are seeing, particularly because there's so much of noise made about the safety and the ease of getting the transcatheter procedures. We often see this even younger patients coming to us and asking for TAVI and such procedures, but they're often limited by cost. Though this is one of the major factors limiting to get the TAVI to many of our patients. So I think. The people are now more aware of this and really want to have this transcatheter therapy in India.
Whilst the appetite,
yeah, please go ahead.
I think whilst the appetite for such therapies from a patient perspective is very attractive, because from a patient perspective, no one wants an open heart surgery. They would naturally opt for a non-surgical option. But I think cardiologists, it's our duty to make sure they are well informed and also go with technologies that have lasted the test of time, so that we maintain the reputation of the therapy that has been maintained over the last many decades. So over to you, Didier.
Thank you. I just wanted to say that this is really a point of similarity between India and Western countries, the patient. The patients are more and more aware about this therapy, and they are willing deeply to get a TAVI procedure. So it comes back to the heart team, and I think what we are promoting and asking the centers is to self-esteem, to understand what are the outcomes when a patient undergoes surgery or TAVI at their institution, to really provide to have a true conversation with the patient, explaining the risks that the patient is exposed to, given the experience of the center, because you could see that depending on the volume of the center, the impact in terms of mortality could be different. So I think we can talk about TAVI and surgery in general, but it's very important to evaluate the outcomes at our institution on a regular basis to get better year after year, but most importantly to provide the right information to the patients, because they are more and more pushing for a transcatheter procedure, and we have to be to get an honest discussion with them.
The other challenge we sometimes face is patients with small annulus, which we often see in India. And these patients, again, we don't have many surgeons who do a root enlargement, and these patients are often put a small valve, and they again come back with the yearly valve regeneration. So these patients may be benefited with the TAVI, even though they are slightly younger age. Maybe with a self-expanding valve, maybe do better off than a smaller surgical valve.
Now, that's a very important point that you make, Sengo, but even more important is perhaps the broader point made by Didier, that if we are going to offer TAVI to younger patients who potentially are candidates for surgery, we have to offer a procedure which is as good as surgery. And the experience and the outcomes may vary in individual centers. And if you have a high volume, highly experienced surgical center, the outcomes may be better with surgery than a low volume, inexperienced TAVI team. So very importantly, when TAVI is developing in an individual center, it's very important that the learning curve is respected, and that in the first steps initially, it should only be higher risk patients who are offered TAVI until the team's experience is established and they can guarantee good outcomes in lower risk patients. Didier, you focused on that in your slides, and you talked about the sweet spot in terms of the number of procedures for an individual center or even for an individual operator. I know in Toulouse you are doing 800 and you do 8 TAVIs a day, and it's a very routine procedure. But how is it rolling out in France? Are there restrictions on the number of centers, the number of cases per center? Is it regulated in any way? And should we apply similar recommendations in India?
Yeah, it's just to serve as a basis for discussion. What is the landscape in France? In France, we have 50 centers, and the regulation is to be able to do like 50 procedures per year. But on average, a French center does about 250 or 300 TAVI cases per year. So we are really fulfilling the recommendations. But I often get that question from a different part of the globe. What is the sweet spot to become more comfortable in terms of achieving good outcomes for the patients? And as you said, Bernard, and this is a very important point, to decrease the risk profile of the patients. I would say like 50 cases, and start with a limited number of operators just to get more experience, and then before expanding, first the type of indication, and second the heart team, the operators, because the more operators you are, the more diluted is going to be the cases, and it's going to be more difficult to get experience. So I would say 50 per year seems to be reasonable.
So important points from the European experience that we can hand to our colleagues in India. Gopi, a brief comment before we move to the first case.
Yeah, I couldn't resonate more with the point that you raised earlier, Bernard. I think it's largely down to what that center is good at in terms of changing the patient's aortic valve. In India, I must say, we actually struggle because the surgical community are extremely good. The surgeons are so good. I'm yet to have a surgeon actually say, oh, this is high risk, better take them for TAVI. They are just good. I mean, whoever have learned as high risk, they are operated on a regular manner with excellent outcomes. So with such good surgical community, sometimes it is reasonable for a country like India, where we are just learning as we go, to give it to the surgeon to give the best to the patient. I think that point has to be borne in mind rather than saying TAVI for all. I think the best aortic valve solution is the best rather than one therapy or the other.
Exactly. So we've covered a lot of information in relation to trends internationally, but also nationally or continentally within India. And we've talked about some of the differences between the patients that we treat, the anatomy, as well as the epidemiological variations. But now let's focus on an individual patient. And we're going to do this initially with a European patient, and then we'll reflect on a more Indian demographic in the second half of our remaining time. So Didier, tell us about a typical patient who came to your care recently in Toulouse.
Okay, so this is definitely a very recent patient because we treated that patient last week. So here is the medical history of the patient, 70 years old male. Another complexity, this gentleman was a former physician. So really part of the heart team, if I can say so. So not really slightly overweight with a BMI of 26, hypertension, and extremely symptomatic due to a severe aortic stenosis. Laboratory-wise, as you can notice, there was nothing very important. Mildly depressed renal function. The pro-BNP was elevated, but this was really related to the severity of the ES, and no inflammatory syndrome. At baseline ECG, sinus rhythm, narrow QRS, nothing noticeable. And on the transthoracic echo, a slightly hypertrophic left ventricle with a very dynamic left ventricle and an LVEF above 65, 72% at baseline. A severe aortic stenosis with a aortic valve area at 0.7 centimeters square. That correlates with a high mean gradient of 65 and a systolic pulmonary arterial pressure more or less in the normal values, normal range for the age of the patient. The coronary angiogram was reassuring, right dominant system without any coronary disease. And this is really what we do, and we recommend that for every single aortic stenosis patient to get a CT scan before we go for the heart team discussion, unless the patient is, for instance, for example, 50 years old. For the other ones, starting from 65 or 70, we do a CT scan, and then we discuss. What we discovered for this patient was, as you can identify, a bicuspid anatomy with a type 1 left-right phenotype that is the most predominant in Europe and the Western countries. And I'll be glad to hear from you guys, Sengo and Gopi, what is the phenotype that is more popular in India. If we watch the right part of the slide, more moderate to severe calcification, more at the tip, predominantly at the tip of both leaflets, but nothing extremely warning to be worried about for the patient in terms of risk of coronary obstruction or hurting the sinuses of Valsalva. This is something that we all do. We, in terms of metrics, first on the left, acquiring the mean aortic annulus diameter, whether it be from the perimeter or the area derived. Here it was around 28 millimeters. And second, on the right part, the left ventricular outflow tract, that was more or less in the same range, 27.4. So more or less a kind of tubular configuration. If we consider that the landing zone, part of the landing zone is going to be from the annulus to the LVOT. But as it is a bicuspid, maybe that's something that we can also discuss, various sizing methodologies. We are strong believers in the Bavard methodology, so we do the commissure to commissure distance at 4. It was here 33. So identifying a flared configuration, so telling us that we can size based on the annulus, 28 millimeters. And we also do that tracing at 4 to 6 millimeters above the aortic annulus. That gave us a 26.5 millimeter on average perimeter derived. And to our experience in type 1 bicuspid, sometimes type 0, it's helpful to anticipate the final diameter once a device is expanding within the patients. We're going to see if it is the case. So nothing noticeable from the coronary standpoint, very high takeoffs, both on the left and the right. And the peripheral vasculature, mildly tortuous on the right, very good diameters, a normal aortic arch, and if we decide to go for TAVI for this patient, a working projection with the TUCAS view, non-coronary on the left part of the slide, and then the fused leaflets on the right part of the slide, which is achievable, RAO 13, caudal 44. In summary, for this patient, Euroscore logistic 3.1, more contemporary Euroscore 2%, STS score 2.5%, so definitely a low risk patient. We have decided to go for TAVI, but I would love to discuss with you guys to understand what you would do if it was your patient.
So thank you so much again, Didier. A great case and a colleague as well. So that presents its own challenges in many ways. And let's focus on that a little, because this patient is clearly well informed. He's a doctor. To what extent is the shared decision-making process in action in Toulouse? Do you discuss and take the patient's views into consideration strongly?
Yes, we tend to integrate the patient will during the discussion, and particularly for this one, as he is a physician, so he was very well informed and willing to get a transcatheter procedure. So we clearly told him that if the anatomy wasn't suitable for a transfemoral TAVI, the best option would have been a surgical aortic valve replacement for him. So he was aware of that. It wasn't a total refusal, denial of surgery from his side, strongly favoring TAVI, but he could understand that if surgery was the best option, we would have pushed for that. So it was really a balanced decision. We took time. So before we moved to the procedure, so we went to see him a lot of times, both with the surgeons, the anesthesiologist, and his family, even his wife, and even his referring cardiologist. I had him on the phone, and we all decided that TAVI was the better option for him. But the patient will was really central in that decision making.
And I think that's a very important point. Before we come into the anatomical considerations, Gopi, you run a high volume structural heart service. How do you configure your heart team? What are the practicalities? Who is there? How often do you meet? Do you discuss every patient or only the complicated ones? Give us a flavor.
It's very, very heterogeneous because by the time the patient comes to us, usually they have met a couple of surgeons and perhaps 4 or 5 cardiologists. So it's probably the most extensive heart team, I would say, in India because it's a private healthcare setup and the patient pays from their own pocket. So, not surprisingly, they want to make sure what they're getting is the best, which I don't blame because the system is such that the patient gets to choose. So, naturally, by the time they come to me, they have done enough homework, making my job extremely easy because the patient has had enough information to make an informed decision. More specifically, coming to your point, we have our surgeon here. They are not in the room. Sometimes they're not even anywhere in the vicinity of the cath lab from a procedural involvement. It's largely done by cardiologists, although there are some surgeons who actually have patients who want to be involved, then yes, they scrub in. But as a routine manner, the cardiac surgeon is not integral part of the procedure, but they're somewhere in the office. But decision making, it's completely patient dependent because here, even if you have a heart team decision that surgery is best, which sometimes they do, the patient is very clear. Doc, I'm ready to accept whatever. I want to go for TAVR, and we have to respect that. And if it's a low risk patient, i.e., younger patient, we go for a time tested technology. With newer technologies coming in, we just have the responsibility to do the best. Bearing in mind lifetime management of the patient, second TAVR or TAVR and SAVR, whatever that may be. But your patient, Didier, I think is a very typical Indian characteristic patient. This is 101 TAVR anatomy here in India. Whilst we're discussing, I have a question in the chat box here. Someone has asked you, Didier, what is the risk of pacemaker and what do you quote routinely for such bicuspid anatomy patients?
So that's a very important question, and that's definitely something that we disclose to the patient because if we are honest, pacemaker is the most frequent complications. We talk about vascular complications, stroke, or even death, and most of the time the patients are fine from this standpoint. But pacemaker is still one of the remaining pitfalls and issues with TAVI. So we have an honest discussion based on the device that we're going to use and their anatomy. We share with them some numbers that we think they are going to be exposed to. With the new techniques that we may discuss afterwards, we can decrease the pacemaker rate, the risk of pacemaker below 10%. But I have to say that bicuspid anatomies, to our experience, exposes the patients to a greater risk of pacemaker conduction disturbances. So we disclose that, and we make sure that the patient understands everything before we move to the procedure. So that's a very, very important point that has been raised by our colleague online.
And any specific anatomical features that you would look for to predict their risk, such as membranous septum? Would you like to touch on that?
Yeah, definitely. So the length of the membranous septum is something. Is it going to predict it all? I don't believe so. I think it's part of the algorithm. If the patient has a right bundle branch block at baseline, if you need to based on the anatomy to be extremely aggressive with a couple of pre-dilatation, post-dilatation to make sure that the stent frame is very well expanded. If you think that you're going to post-dilate, most of the time you are not deploying the device very high. So as a matter of fact, at baseline, you expose the patient to a greater risk of pacemaker because you are deeper. And then you add a balloon on top of that. So I think the membranous septum is part of the equation, but I would also integrate the baseline ECG, LVOT calcification, and overall the complexity of the procedure and the number of maneuvers that I think I'm going to need for the patient.
So we should reflect a little bit more in detail on the bicuspid anatomy. And before we go to the next question, just to emphasize to our audience that the chat function is open and Gopi is ready and collating your questions. So please do not hesitate to ask anything of detail in relation to these cases. But Sengo, let's come to you in relation to the bicuspid anatomy, because there's certainly been evidence from some of the European studies that the outcomes of TAVI in bicuspids are maybe not as good as we would hope. Is that influencing your approach? Are there certain anatomical configurations where you would say that TAVI was the wrong option?
Absolutely. I think bicuspid has got such a heterogeneous population where it can be from forms where the anatomically very suitable versus very, very unsuitable or kind of difficult anatomies to do TAVI. So it depends upon the type of the bicuspid valve, the amount of calcium, the calcium location. So it's a number of factors like the coronary arteries, whether the height of the coronaries, as well as the patients we were discussing about the higher risks of the pacemaker and maybe also the stroke and the iotopathy. So all these are in consideration, and particularly in Indian patients, we have to balance the age of the patient and the anatomy, and then we discuss with the heart team and decide which is the best option for that patient.
Let's change gear now and think about the coronary arteries, Didier. There was a time when every patient before a TAVI would have an invasive coronary angiogram. Every lesion would be stented, and the procedure became far more complex and potentially riskier as a consequence. How has your own practice evolved in relation to evaluation of the coronaries and also the treatment of any coronary disease that you encounter?
So I have to say that it's well, I like the discussion that we are having because it's really the daily challenges that we are facing, and we are for this matter we are still evolving. So we try to tailor the screening test to the patient, the risk profile of the patient. So if the patient has a past history of coronary artery disease or sometimes extremely calcified, we can see calcified coronary arteries without on the CT scan without any contrast and so on. Most of the time we do a coronary angiogram because we want to make sure that we don't have any proximal disease, because as soon as the patient is extremely calcified, as calcium, it's difficult to identify or rule out coronary stenosis with a CT scan. So we tend to do the coronary angiogram for these patients at high risk of high likelihood of coronary artery disease. For the younger, low risk patients and for whom we don't think that there's going to be an issue with the coronary arteries, we rely on the CT scan because when you don't have the calcium, you can really have a very nice analysis of the coronary distribution and the coronary lumen. So we try to tailor to the patient. But when I was in Tokyo for Tokyo Valve, I could see experience from our Japanese friends and APAC friends that they tend to skip the coronary angiogram and rely only on the CT scan for the proximal lesions only. We are still tailoring the screening test to the profile of the patient.
And in terms of any intervention for any coronary disease, you're only intervening if the patient has angina or if it's a proximal lesion. Is that what you're implying?
Yes, still we do the same proximal lesion. We tend to treat it if the amount of myocardium at risk is jeopardized. We have to keep in mind that in the past we were using devices that sometimes made our life very challenging in terms of getting access afterwards to the coronary arteries. So we had the temptation to treat the coronary arteries, any coronary artery disease before, but now the new iteration, the second or third generations of TAVI devices with large open cells, the commercial alignment really are user-friendly, and it's easier to get access to the coronary arteries. So sometimes, if, as you said, if there is no angina, we tend to focus only on the aortic valve, unless there is something at the SGM of the left main, LAD, or right coronary artery.
Perfect. So before we move on now to the step-by-step approach, Gopia, do we have any questions from our audience?
I'm inundated, Bernard. I'm trying to select some relevant questions. Let me throw a question. Do you routinely provide cerebral protection? Is one of the questions. I think that's very relevant. Do you want to take that, Didier?
Yeah, I think there is First, we have to be honest and acknowledge that the data don't support the systematic, routine use of cerebral protection devices. But once you have used these devices, you can identify that there are almost in each case something within the baskets, within the filters. So once again, it may sound a little bit counterintuitive, but the younger is the patient, the more likely the use of a cerebral protection is going to be at our institution, because we think more about the future of the brain. Maybe the plasticity of the brain is less important in a younger patient, and any damage is going to have a greater impact in terms of cognitive impairment, even though we don't have an immediate stroke immediately. So younger patients, bicuspid patients, complex valve in valve, we tend to use a cerebral protection device, but for the vast majority of the patients, we don't.
So, if you were to summarize for the audience, is it reasonable to say there is no scientific evidence, but it makes a lot of theoretical sense to put a filter because we see debris coming out and we don't know what is the long-term result. Therefore, if you feel the patient is young and has some high-risk indicators, better off using it even though there is no evidence. Is that a reasonable conclusion, Didier?
That's a perfect summary. Thank you.
So Gopi, we've got time for one or two more quick questions and quick answers before we move on.
Okay, another relevant question from the audience. Do we balloon dilate before the valve, self-expanding or balloon expandable valve? I think it might be relevant for this bicuspid valve. The question specifically is balloon dilatation necessary for self-expanding or balloon expandable valve? For this case, Didier, you might want to take this answer.
Yeah.
So,
Yes, please go ahead.
So I think you're going to see what I did. So maybe Sengo, it could be interesting to hear your experience, what you would do for this patient.
Yeah, I think for sure it depends upon the anatomy. I think with the kind of anatomy when now we have very less calcium, and you think most of the time we think of avoiding a pre-dilatation. But I think it's important to understand that the valve expansion is very important to achieve a good expansion at the end of the procedure. And in a self-expanding valve, if you don't pre-dilate, sometimes it might be difficult to achieve the good amount of expansion. Unlike a balloon expandable valve, which has a more radial strength and can still have a better expansion even if you don't pre-dilate. But there are other considerations as well. To maybe in a bicuspid valve, we would more tend to pre-dilate. And we also have to understand that if you use multiple devices multiple times, there may be a slightly higher risk of stroke or even a pacemaker when you go and you do more of active dilatation. So all these considerations, and in majority of the cases today, we don't try to pre-dilate, particularly when the anatomy is very favorable with less calcium.
So all will be revealed when we see the case from Didier. One more question, Gopi, and then we'll move on.
One question is, are there any contraindications for TAVI?
Very important, very good question.
Yes, thank you. I will let you take that.
So who is not a good candidate?
Yes.
I would say extremely a young patient with an extremely hostile anatomy, diffuse calcification. If you take a bicuspid, calcified raphe, extensive calcium of the leaflets, narrow sinuses. Bernard has mentioned the coronary risk. If you have low coronary takeoff and you think that the risk of coronary obstruction is too high, I would avoid TAVI for this patient. Sengo mentioned the issue of small anatomies, and I think that's another issue. If you believe the surgeon, your surgeon can do a very nice root enlargement and put a very large device, and for a patient with a longer life expectancy, keep the door open for a valve in valve, I would still consider surgery for this patient first. And at last, if you don't have a suitable, a very nice transfemoral or transaxillary access, sometimes it's better to go for surgery and get a very nice surgical aortic valve replacement, because we have nowadays very limited vascular complications, so we have to avoid that as well.
I think as an absolute contraindication, will it be reasonable to say sepsis and recent stroke will be the main absolute contraindications and the rest are all relative? What do you think, guys?
Yeah, I think it's fair. It's fair to say. So if you have a sepsis, surgery has proved to be efficient because you can remove it all. You can really clean the area, the aortic root complex. We can't do that with TAVI. So definitely endocarditis, sepsis. I would avoid TAVI for these patients.
And we should also just briefly mention the issue of frailty and futility. So if the procedure is not going to benefit the patient in overall terms, that would also be an important consideration, particularly in the very elderly population. So Didier, we could be here talking all night about TAVI and all these different aspects, but let's now move to the procedure and take us quickly through your step-by-step A to Z.
Yeah. So the procedure, we always start with, you can see the setup of the patient, one radial access, one femoral access, and we have, you can see that brown crocodile clamp. We do the direct wire pacing. I'm pretty sure you do the same, guys, because it's a trend worldwide to do the echo-guided puncture. I tend to do it in the long axis view. I scroll from medial to lateral, identifying the greater diameter of the common femoral artery, keeping the femoral head as the reference. I keep it at 6, and then I know that if I puncture in that area, it's going to be safe for the patient. So I'll be avoiding to dive into the retroperitoneal space with the external iliac and avoiding the bifurcation. And you can see that even in that long axis view, you nicely see the needle. If you keep it parallel to the probe, you can do a very nice stenting because it's a thick vessel, the common femoral artery, and really decide on the entry point and the location. What we do, our technique is a single proglide, and we combine that with an angioceal at the end. I've seen that at 2 centers during my experience, and one of the centers was London, St. Thomas's. So it tells us about the exchange of solutions, and I like to discuss with friends worldwide because every time you learn something new. So that first, removing the slack technique, I brought it from Japan, from Kentaro and Ashida. And second, one proglide and one angioceal. I took it from the guys at St. Thomas's. So thank you very much for that. It has improved the outcomes for my patients. So the procedure, definitely. We talked about the two cusp projection, RAO 13, caudal 44. It was not that difficult to cross using not really the picking technique, but more the sliding technique, bending the wire and then push-pull with a slight clockwise rotation of the L1, and it was very easy to get inside. We 100% of the time for any single device, we do a hemodynamic assessment. Here you could see, and it matched what we saw in terms of mean gradient for from the transthoracic echo. Peak-to-peak gradient was around 60, so really a very stenotic aortic valve for this young patient. So we did a BAV to answer the question from our friend in the audience. The plan here was to use a Sapien 29, but even for a balloon expandable platform, we do a BAV, and we inject some contrast. First, you can see that we don't seal the anatomy, so a 23 millimeter balloon was too small for sure. Second, you can see the movement of the calcium and the fibrosis, and particularly on the non-coronary side, you can see how close the leaflets get to the wall of the sinus of Valsalva. So the expansion, we know that the expansion of the TAVI platform has to be very gentle. So for our friends online who are not really familiar with the Sapien platform, Sapien 3, so it has the ability to bend, to flex, and we can really flex the catheter, the commander, to really try to match the anatomy of the patient and to really be perpendicular. And once we are across the aortic valve, what I like to use as a landmark is the radiolucent line. You can see it once you get the contrast, and I put the radiolucent line at the annulus, and this is going to provide to get us a very high implant at the end to decrease the rate of pacemaker for our patient. So here is the deployment, radiolucent line at the annulus. You can see no right ventricular line at all. So the pacing is done with the wire. And just to reassure the audience, because one of the questions that we often get is it reliable? How stable is that direct wire pacing? It is. There is no 100% in any case in medicine, but for the vast majority of the patients, you can get a very stable and very controlled pacing for our patient. Once again, even if it was a balloon expandable platform, we did the hemodynamic assessment. So first you can identify an increase in the duration of the QRS with a incomplete left bundle branch block, but no gradient. LVED remained the same and a very high diastolic aortic pressure. And this correlated with a high implant, as you can see, a device that is quite well expanded. This was the two-cusp view, so in fact it matches the minor expansion of the aortic orifice, and we could see that even in that projection the device was very large, but we did check into orthogonal projection. No regurgitation, patency of the coronary arteries, and no pacemaker for this patient, so we didn't put any right ventricular lead. Something that we do for those complex patients, and remembering that this patient was a young patient, first we could see that the commissure alignment wasn't perfect. One of the commissure was really in front of the left main. And second, if you remember the supraannular tracing that we did, it was around 26. And here it was ranging from 24.5 to 26.7. So we could anticipate the maximal expansion of the device in the anatomy of the patient. So to hand up, no real change in the LVEF on day 2, discharge of the patient. EOA quite large enough for the BMI and the body surface of the patient. Mean gradient of 11, no aortic regurgitation. So, and this patient is going to be followed up by his referring cardiologist 30 days and on a yearly basis. Thank you for your attention.
That's super. Thank you so much, Didier. Just quickly tell us in terms of the longer term follow-up, the patient you'll discharge on day 1 or day 2, would you expect them to have an echo at 1 year and every year after that?
Yeah, and at least an echo at 30 days, the first one, because we part of the discussion is the evolution of the gradient and the pattern of the gradient, because we can see sometimes a slight increase, and at least to be able to get a baseline echo baseline gradient, I'm more relying on the 30 days echo rather than the discharge one, because the patient is active and it's really a more steady state, and then we do it on a yearly basis.
And another point that we mustn't forget is that we also advise the patients to take antibiotic prophylaxis when they have dental procedures. That's something that's often overlooked these days, but that's an important piece of advice for the referring and the follow-up cardiologist.
Exactly.
So lots of teaching messages there, Didier, but maybe we'll reflect on them in parallel with the case from Gopi from India as we transition and make use of our time together. So by means of a link, we'll now come to you, Sengo, and some reflections on the evolution of practice in India and the expansion of transcatheter technologies.
Yeah, sure. Thanks, Bernard. So can I have the slides here? So as we see, the TAVI program in India was started a bit late compared to the West. We started it many years later. But the majority of the world population, we know that around 60% live in Asia. And also the population has started to age. And the adoption of TAVI has been a little slow. We know the several challenges, but it's now actually India is really overburdened with the iliac stenosis patients. The numbers are huge, but many of them are eligible, but it's not in the reach of the individual because of many reasons, which I will elucidate now. So the patients, many patients in India are mostly younger, whereas in compared to other parts of Asia, and the anatomy is sometimes a little different. So the annulus sizes are small, and some of them have a small peripheral axis. And again, I was discussing this earlier. Many of these patients actually will undergo just one procedure in their lifetime. As an average life expectancy is 67 years. And rarely, some of the patients may require 2 procedures in their lifetime. So not just small annulus, bicuspid prevalence is higher. Is usually what we see is again type 1A the bicuspid disease, what we see often. And it's the small annulus is also, we see a small body surface area, and we also see a very challenging anatomy with more calcium. And these are some of the challenges which are there of the hostile anatomy in patients who are planned for the transcatheter procedures. There are a lot of health system challenges also. We know the cost, the economy is a big issue, and there's no reimbursement, and the insurance is less coverage, and most of the patients do not have insurance. And there's also a lot of delay in the regulatory approval and delay in getting these valves to a country. And also the less trained TAVI performing operators, which is now slowly increasing. But this is one issue which was there when we started the program some years ago. So earlier, when we started the program in 2012 to 15, those days we need to apply a special license to get access. And then we slowly started getting the approvals for core valve, got approval in 2016. I still remember the first core valve we did in 2015. And then the 2 indigenously developed valve, particularly the My valve, really changed the practice in India. And the access to TAVI actually increased in many number of centers in India. And subsequently, there were now many of the available valves are now commercially available. And we also have more number of trained operators. And the growth is expected to increase tremendously because of more expertise and availability, and also the cost a little bit coming down with the indigenously developed valves. Can you move to the next slide, please? Yeah. So if you look at the growth over the years, you can see that it's growing overall, and it's still projected to rise. The numbers are still going to rise. Almost you can see the growth is exponential and projected to be very high in the coming years. Though we started very late in 2017 and 18. Next slide, please. And if you see the availability of devices, you can see that the initial valves were from Medtronic, and then the My valve. We started Sapien in late 2016 and early 2017. And subsequently, another indigenous valve called Hydra, which was there from 2020 onwards. And then we started having all the valves like Portico, now the Navitor, and the My valve, the new generations, and now the Evolute Pro Plus, and also the FX now being available. Next, please. So you look at the market share, it's still the majority of cases by the Merrill My valve, which is almost 60% of the market share, which is being used in India. Next slide. So if you look at the number of cases being done, there's almost about 100 plus independent operators in the country, which happens in about over 75 cities. But if you look at the high volume centers of which is more than 100 TAVIs per year, it's only about 10, slightly more than 10. And centers performing at least one TAVI is about more than 450 centers, which means that many of these small centers do want to call a proctor and get the TAVI done. But again, that, as we said, the experience is less, and maybe they should just stick on to very high risk patients who are not suitable for surgery. Next slide, please. And if you look at the clinical trials, many of Indian patients are not very underrepresented. But now, since we have this My valve, we are now having more number of trials coming in. Recently, a 4-year durability data was published in Eurointervention. And again, we still need long-term data and the valve durability studies, with particularly in Indian patients, which is really lacking. So I think with this, I think we are still far lagging behind, but we hope to catch up with the growing number of procedures and the growing number of indigenously developed devices. Thank you.
So thanks very much, Sengo. And perhaps just to complement that very nice presentation, just a few words very briefly, Gopi, about mitral and tricuspid. Are you seeing the takeoff of those technologies as well?
It's largely been mitral valve in valve and tricuspid valve in valves. There are no indigenous TMVR technologies yet in India, although there is mitral and tricuspid repair in the form of TIA. The mitral is taking up, mitral and tricuspid valve in valve are taking up excellent, huge numbers. Everybody's gaining experience. Since we did the first TMVR in 2016, it's been a prolonged journey, but then a very, very quick journey. And as Sengu mentioned, with the advent of cheaper valves available, the expansion has been very good and favorable and good for the patients.
Yeah. And the other thing that we've learnt in Europe is the central importance of imaging. And as I was listening to the presentation, I was reflecting on the learning curve that's associated with image interpretation as well. And Didier, in your hands and in your team, the interpretation of the CT is now very much the domain of the interventional operator rather than the radiologist or the imaging cardiologist. Do you want to say a few words about the learning curve for image interpretation?
Yeah, I think that's really something, a very important point that you stress out, Bernard. We need to master CT scan and imaging in general. It's important for TAVI. It's going to be even more important for mitral and tricuspid. If we focus on TAVI, what we did in Toulouse was first, as operators, to learn how to interpret the CT scan, and we've trained each of our fellows. Each one of them gets a proper training to be able to prepare the CT scans before the procedure, and withdrawing that burden for the radiologists that just do the acquisitions, the rough estimation of the femoral arteries, and then we download the CT scan, the DICOM, and we do our own analysis. This way, they can absorb the overload of CT scan, the demand for CT scan for us, and then we do the job, and we train every physician who is part of the TAVI program to analyze the CT scan. And just to finish on this point, I do believe that if you do your own CT scan, it's a kind of preparation to the procedure, anticipation of the complexity of that you're going to meet during the case. And I have to say that I still find it a little bit strange when a physician totally relies on the company to provide the matrix of the patient and tell us what valve we're going to use, what size. I do believe that this should remain a physician's decision, taking into account all the complexity of the anatomy of the patient and even the medical history of the patient. So we should be the masters, and we should adopt and acquire the skills at analyzing our own CT scans.
That's exactly right. The analogy I make, Didier, is that you would never allow somebody else to choose the size of stent that you deployed in the left main. You would make that decision as the operator and as the doctor looking after the patient. So it should be no different principle for TAVI. So Gopi, we're now going to come to an Indian case, and I think you've animated this with some PowerPoint and some short movies. Do you want to make an introduction?
Yes, so we will just move on to the case. They've been split into 5 parts, including the history, followed by imaging and planning, followed by ultrasound guided access, which we have shortened because Didier has explained in detail. Then we will do the implantation procedure, and then we will do the procedural endpoints and closure. So let's move on there.
Good morning to the PCR webinar, where we're going to demonstrate a live TAVI demonstration from the Heart Valve Center here in India. I will start with the case presentation. Our case today is Mr. K. He's an 80-year-old man. He has symptoms of breathlessness on exertion. He's had a previous coronary artery bypass grafting in the form of LEMA and REMA to the LAD, OM1 and OM2 with jump grafting, obviously, in 2013. He's been well since then. Until last 6 months, he's been troubled with increasing breathlessness. Clinical examination revealed an ejection systolic murmur, and his echocardiogram showed significant, severe aortic stenosis. His LV function was normal. There was no other structural abnormality on his echocardiogram. He underwent a CT examination, which we will go through in a second. But what it did show was patent grafts, suggesting his lima and rima were patent with excellent distal flow. His ECG showed sinus rhythm and no conduction abnormality. Both AV conduction and intraventricular conduction were normal. We will go through the imaging now, and we will take you through the steps of the TAVR procedure.
Let's jump to the next slide, Gopi, and see the first steps of the procedure, perhaps.
Echocardiogram, transthoracic. You can see here there is clear suggestion of restricted aortic valve opening consistent with aortic stenosis. This is a zoomed view. This is calcific. You can see the bright echoes and restricted mobility. Color Doppler suggested no significant aortic regurgitation. A zoom-in view, a short axis of the aortic valve suggested a tri-leaflet valve with 3 sinuses. And these are the gradients that we could measure across the aortic valve. You can see here the aortic valve mean gradient was 40, and the calculated aortic valve area was 1 centimeter square. The LVOT velocity was normal. Moving on to the CT analysis of this patient. Okay, I think I'm exactly at the nadir. I just want you to concentrate on this short axis. You can see here, this is the aortic valve short axis, and I'm sure everyone will be convinced that this is a tri-leaflet valve. You can see 3 sinuses. At this plane, I've just zoomed in that image. I'm going to measure the aortic annulus. So you can see here, this has a minor diameter of 1.9 centimeter, and the major diameter is 2.4 centimeter, giving us an average of 22. The left and the right are both fairly good caliber vessels at the common femoral level, and they measure about 8 millimeters. There's a small speck of calcium posteriorly in the left common femoral. As it becomes a common iliac, you can see here there is significant calcification both of the right common iliac and of the left common iliac. In the left common iliac, it's almost 360 degree, although there's a small area that's been left behind, and the lumen is not very generous. If you look at the short axis, it is only 4.8 millimeter. Mind you, these lumen calculations can be overestimated because of the blooming artifact, which one can adjust to as little as possible, and sometimes you can make it as much as possible, as I have done here, to make sure we don't overestimate. And as I come up here, it becomes even more calcific. The left here is significantly calcific. There is I'm going to zoom in a bit more. There is a big nodule of calcium, and you get the feeling as though small spicules are protruding into the lumen. It measures 7 in one direction, and here, I don't know, maybe 4. I think we're going to have a problem dealing with the femoral artery in this patient if we were to choose a transfemoral axis. So in this case, we will use the left common femoral because the right iliac is severely stenosed, and we will also prepare the left iliac with lithotripsy to try and modify the calcium so that we really don't have any problems. One of the reasons we want to go up front with lithotripsy is because of the position of the calcium. It's very, very proximal, just next to the bifurcation. It's unwise to push a sheath. We might get away, but then as we come out, if there is a rupture, it's an odd position to be fixing with a covered stent, and one has to end up doing a Y graft in the form of an EVAR device. So to try and avoid, we are going to use lithotripsy lithotripsy up front for the left iliac, soften all the calcium, and then try and take a sheath or a device without a sheath. We will see how it goes, but certainly not the right side because of significant calcification. In terms of lifetime management, given his age, he's now 80, we don't anticipate he will have too many problems if we were to use a self-expanding valve in the form of a Medtronic Evolute R FX. And if he does need another valve, we'll be very happy to put any valve because coronary is not a problem because he has patent grafts. So we shall get on with the procedure and let's see how it goes.
So a potentially challenging femoral case, and I think you used ultrasound guidance for safety and security of the puncture, Gopi. Do you want to show us that, and then we can take a question or two?
Sure, let's move on.
So I hope you can see my needle going down, and here I hope you can appreciate I am just trying to tent the anterior aspect of the vessel, and I'm ready to puncture. I'm happy. Okay, going in. So I have a good flush back, and as I have a good flush back, I normally bring the angle to 45 degrees so that the wire is able to traverse the artery with ease and not go and hit on the posterior wall.
We can take any questions there.
Okay, so we're nicely ready for the remainder of the procedure, but in terms of the ultrasound guidance, Didier, you've already emphasized that this is a routine procedure that you use in all your patients now. You've seen the benefits, but what about micropuncture as opposed to a conventional gauged needle? Have you adopted that?
I have to say that it's not that popular in France. I've seen that in a lot of at a lot of centers, whether it be in the UK or in the US. It's really popular. I would say that if the patients, I had to treat a patient that is very obese, and I want to double check and make sure that I have a very nice puncture of the common femoral artery anterior aspect. I think a micropuncture makes sense because you can combine the safety of the ultrasound guided puncture, and then you could even inject some contrast at the entry point just to make sure that you are at the right spot. So I do understand the benefit, but I have to say that it's a personal decision, and potentially if you start your experience, you could this could be a great way to secure the access. I agree with that.
And Gopi, do we have any burning questions from our audience? I'm sure there are many.
Yes, the difference between do we need micropuncture for all is a question which perhaps I will take because this is from India. And I think it's largely down to what you're comfortable with. I'll tell you what I do. I used to do a lot of micropunctures when I don't see what I'm doing. So it makes sense to make the smallest hole, do an angio, and if you don't like it, you can do another micropuncture. But if you're going to see what you're doing, like ultrasound guided, you can see the needle going in, then you know where to go, and you might as well go for a macropuncture. And therefore, I only do a macropuncture, not a micropuncture. But largely, it's down to what you're comfortable with. Doesn't matter what puncture you use, whatever you feel is comfortable, and you can safely bail out, I would say.
Okay, and any other questions? As many as we can squeeze in.
There's a question on what are the preferences in terms of antithrombotic therapy post TAVI, or everybody now agrees on clopidogrel monotherapy. Do we need to, shall we take that question now or towards the end?
Well, let's take it quickly while it's in our minds. So Senga, what's your practice? Single antiplatelet therapy?
Yeah, absolutely. Most of our patients do not have an indication for anticoagulation and just TAVI, and those patients will go with the single antiplatelet agent, mostly aspirin. And I don't think there's much data for clopidogrel alone, but of course we tend to use clopidogrel for some patients who do not tolerate aspirin. And of course, patients who need, who are in atrial fibrillation or on stents, previous stents, and of course, we modify their regimen, and maybe they will need anticoagulation. Or in some patients like valve and valve, particularly mitral valve and valve, we wanted to give at least a short period of anticoagulation for 3 months and then we change it over to a single handle platelet.
Okay. So Gopi, I don't want us to run out of time. So let's see the remainder of the procedure, and then we can use the remaining time for any questions.
So today we're going to do an injection of the aortic bifurcation to visualize the left common femoral and the left iliac system, because we know the significant disease. We want to have an angiographic idea. Inject, please. So I hope you can see the cine. I've not moved my table. You can see the aortic bifurcation, the calcium very nicely. We're going to treat the proximal part of the left common iliac vessel. I hope you can see the console that is emitting rapidly. We just released 30 pulses there. Okay, I'm taking 18 French sheath. We'll be very careful as we traverse the common iliac, and we'll see some resistance here. I don't want to push further. Okay, so what we've done is as soon as we faced a lot of resistance, I didn't want to push the 18 sheath, which will be an outer diameter 21. So I have taken out the 18 French sheath, and I have just for hemostasis, I have put a 14 sheath and tightened my ProGlide knot. We're going to cross the valve. We're going to put a Safari inside the LV, and then we're going to go sheathless with the Medtronic Evolute FX system to try and minimize the size that traverses this diseased iliac artery. So we're going to try and cross the valve. We've not injected the root yet. It is routine. We don't inject the root until we have the stiff system through to try and minimize contrast load, unless there is another reason to inject the root at this point. There you go. I hope you saw that. We've just crossed the valve. Far, so good. So you can see the device coming up. We're just making sure the wire is on view for us. And that's the moment of truth. And there we go. I think we may have had the device through the diseased area already. Less wire. The inline sheath has clearly crossed. I hope you can see the hat marker there posteriorly, and now I made it more lateral. So if you correlate that to the flush port, it's about 2 o'clock position. So we're going to maintain a 2 o'clock position, hoping this will get us commissural alignment. And for commissural alignment, you want to do this final check also. We have checked the hat marker was on the lateral aspect on LAO view. On RAO, you want the hat marker on face. So you can see here, I hope you can appreciate, the hat marker is facing us. This suggests that we are indeed in the best possible commissural alignment one can achieve with this device. So all good. The valve usually tends to dive down, which is why I've started quite high up, and we'll position it. Let's get the capsule out. Open, 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 wait, open, 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 open. Stop. Okay. Start releasing above. Open, slowly. Open, 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 open. Okay. Great. Okay, I think we are fully released there. Okay, here we have hemodynamic information. We have placed a pigtail in the LV and one in the aorta above the valve. We have simultaneous gradients. The red pressure that you see there is from the aorta, and the yellow pressure that you see there is from the LV. So essentially, no gradient. Both systolics are 130, and this is a great result. You can see the diastolic pressure is 66. Now we will proceed with an echocardiogram. Okay, the aortic valve is wide open, and I don't see a speck of AR there, which is pretty good. 3-chamber view, please. And a gradient also. What do we have there, Lalita? Mean gradient? 3. Okay, great. I think that looks very good.
So we'll stop there.
The last. Sorry.
Do you want to show us the closure, Gopi?
Yes.
So we're going to show now vascular closure. I hope you can see.
Seems there may be a problem with the sound there, Gopi. Maybe we'll forego the closure because we saw a nice closure from Didier's movie, or we can just watch. Maybe you could speak over it yourself.
I think the closure pretty much we used the Didier's technique, which is one proglide and one angioseal, which is our routine, which did the job. And final checks, of course, we do the DSA from the left radial artery to make sure the vessels are good, and that hopefully will come up any minute. And with that, the procedure was closed, and procedural endpoints were very satisfactory.
So we'll leave the movie running just while we discuss the closure. In terms of the backup that you have for any vascular complications, do you have the vascular surgeon in the room or in the hospital? What precautions do you take?
All teams are in the hospital and not in the room, and we call for them when needed. But almost 95% a percutaneous bailout is adopted, and that has largely stemmed from the experience of planning. And pretty much we can predict who's likely going to need, and if that is the case, we will have them in the room. But that is increasingly getting smaller.
And in terms of the inventory of skills that you might need to put in a covered stent or do a crossover technique, that's all within your team, is that right?
Yes, absolutely. So, as a rule, we always have access to the vessel that we are closing in the form of a wire. So, if it is the contralateral femoral, then we have a crossover. It's from the ulnar, then we leave a wire down whichever femoral we're going to close, so that we have quick access for balloon occlusion should there be a bleed. And in terms of inventory, it's mandatory to have all the endovascular covered stents and skill set, more importantly, to be able to deal with them swiftly. If not, it's best to get somebody who has a lot of skills. Usually it's the radiologist or the vascular surgeons.
We have seen on kind of a different way of closing. What we do is in almost all the cases we use just one proglide, and what we do is we close the proglide, and 80 to 90% of the cases we don't need an additional angioseal. Only in about 10-20% we need an additional angioseal. That's been doing it consistently with just one proglide most of the cases.
Sure.
So Gopi, it seems that our time is running to a close. As the audience will have gathered, this group of colleagues could talk about TAVI for the next 3 days, and we wouldn't be guilty of repetition. But I think it's been a very valuable composition of different aspects of the TAVI procedure, the contrasting international experience, and also the specific details of the individual procedures. Tell us a little bit more about the plans for the rollout of this webinar program, Gopi.
I think it's been fantastic, this 90 minutes learning experience, certainly for me, looking at Didier's case and the other presentations, and I hope it was educational for all. The long-term plan with this inaugural webinar is that we will have regular PCR webinars in association with India Valves, with various Indian faculties who have grown the therapy to where it is right now, concentrating on a single topic. Like today, we concentrated on TAVI, giving a holistic view of the European state of the art and the Indian state of the art, and the landscape with my colleague and superstar Sengutwil giving the landscape of Indian TAVI. Similarly, we will have TMVR, TTVR, perhaps electrosurgeries in one webinar. So this is going to be a regular session, and we're really looking forward to that. Adding to that, the India Valves physical conference is due in September, the first weekend. So please log into the website indiavalves.in, and we're looking forward to seeing a lot of our friends and colleagues to mutually learn from each other. And Bernard, perhaps you might want to touch on the forthcoming London Valves, which we are also looking forward.
Well, we shouldn't, of course, forget London Valves, the beginning of all the PCR valve courses, and to publicise and welcome you all to London, November 16 to 18, 2025, at the Excel Centre in London. So thank you to this wonderful team for the educational experience of the last 90 minutes. Thank you all for joining us, and we will publicize through the India Valves app the date of our next webinar together. Thank you all very much indeed.
Thank you.